What if your eyes were working perfectly, but your brain couldn't understand what they were seeing? You look at a pen, you see its shape, its color, its movement. But somewhere between your eyes and your mind, something far more complicated is happening. Because eyesight and vision are not the same thing. The eyes capture information, but it is the brain that turns that information into meaning. And when that system goes wrong, something extraordinary can happen. A person can see a face but not recognize their own wife. They can look at an object but have no idea what it is. They can see the world but suddenly lose half of it. And in some of the most fascinating neurological conditions, the eyes may be completely normal while the problem lies deep inside the brain. In this special episode of Rebooting the Brain, we are joined by Dr. Sujit Kumar, a neuro-ophthalmologist, to explore the remarkable connection between the eye and the brain. From the optic nerve and the visual pathways to the mysterious world of visual agnosia, color blindness, visual hallucinations, and blind sight, we discover how much work the brain does before we can simply say, I see. But this conversation isn't just fascinating neuroscience. It could also change the way you respond to a change in your vision. Because sudden loss in vision, double vision, transient blurring, a missing part of your visual field, or even unexplained difficulty recognizing things may not always be an eye problem. Sometimes they can be the first warning that something is happening in the brain. A stroke, a tumor, optic neuritis, raised pressure inside the skull, or another neurological disorder. We explore why some patients regain their vision, why others learn to navigate a world that has suddenly changed, and how the brain's remarkable plasticity can sometimes help it adapt. Because the eye can give us more than the ability to see. It can give us a window into the nervous system itself. From the blind spot that everyone has, to the visual world our brain quietly constructs for us, from the first warning signs we should never ignore to the extraordinary ways the brain can adapt after injury, this is a conversation that changes the way you look at looking. This is rebooting the brain, and sometimes the eyes are the first place the brain tells you something is wrong.
ജ്ഞാനാനന്ദമയം ദേവം നിർമ്മലസ്ഫടികാകൃതിം ആധാരം സർവവിദ്യാനാം ഹയഗ്രീവ ഉപാസ്മഹേ ഹയഗ്രീവ ഉപാസ്മഹേ.
Rebooting the Brain, powered by PRS Neurosciences.
Namaste, everybody. Welcome to another episode of our podcast, Rebooting the Brain. Today is another very exciting episode. You know what's the title of the episode? Eyesight is not equal to vision. Interested? You will find out more. Let's start with the Shanti Mantra first. Om Asatoma Sadgamaya Tamasoma Jyotirgamaya Mrityorma Amritam Gamaya. Om Shanti Shanti Shanti. This shloka has been my favorite since my childhood. And as the shloka says, from darkness to light, from ignorance to enlightenment, and from death to immortality. You can use this anywhere in your life and get success. And every episode of ours is doing this. That's why I chant this mantra, because you do not know what happens, and then at the end of the day, you understand what is going on. So hi everybody, my name is Dr. Sharan Srinivasan. I'm a functional neurosurgeon in Bengaluru, India. And before I introduce the guest of the day, some housekeeping rules. Don't forget to subscribe to our channels, the YouTube, Instagram, Facebook, called Rebooting the Brain. Please make sure that you hit the like button, share generously, subscribe, hit the bell icon, and most importantly, make your comments, because generous comments helps us to increase the reach to more and more people who you never know who in the family will get benefited by the content that we are creating. We also have written our first book called Rebooting the Brain. It's available on Amazon. It was an Amazon bestseller. Please buy it and read it. And we also have the second book behind our guest, which is Neurojustice, So many things to do. The Rebooting the Brain podcast, lots of stuff to go, and obviously the previous episodes. So, what is this, guys? I'm like the magician removing something from the cap, from the hat. All of you say it's a pen. Is the eyes telling it's a pen or brain telling it's a pen? Interesting question. All of us say, no, can't you see with your eyes? We never say, can't you see with your brain? Have you ever said that? So imagine you're sleeping now, guys. I carefully open your eyelid and show the pen. Do you see the pen? Are you blind? No. Why don't you see the pen? Because the eye is on, the brain is off. Interesting. So today I'm going to talk to a neurologist who's going to open your eyes and make you see the vision. Sujit, welcome to our show.
Thank you very much.
Dr. Sujit Kumar is a very senior neurologist, epileptologist. The third designation, I'll tell you a little later what else he does, but he's a great buddy of ours, and so you're going to hear from the master himself.
That's my son, my oldest son, with Santa Claus. Yeah, Santa Claus, my oldest son. And this is one of my youngest son. When he was younger, he's a teenager now. But yeah, that behind that angelic face is a demon child. That's my eldest son when he was, must have been about 6 weeks old, 2 months old. I think that's me. Yeah. And that's Hayden, my youngest son, when he was a baby.
And do you see the details of the face? Like, do you see the eyes clearly? What is it in the image that you recognize?
The whole face. And I'll tell you why you can see, I can see a whole face, but I can't see a whole object. Like this thing here, I only see parts of it. Like, I see these diagonal things here, but I can't see the whole thing. But with the face, I see the whole thing. So you say, well, how come I can't see that in its entirety, but yet I can see the face in its entirety? It's because a completely different center of the brain processes faces than processes objects. And in me, the part that processes objects, symbols, has been damaged, but the part that processes faces is fine. And that's how I'm able to recognize people's faces. I recognize my colleagues at work, my family. That's much, I'd much rather have the condition I have. I'm lucky, because I'd rather have that than not be able to recognize faces. That would be awful. Not being able to see the people you love anymore.
Sujit, you just saw a video of this patient who was recovered, walking around seemingly okay, but not okay. He sees, but he cannot see. And I know that's a term that we use called visual agnosia. So let us jump straight into this topic. What the hell is visual agnosia?
As you must have seen in the video, and as Dr. Sharan has appropriately told, seeing the pen is not just with the eyes, but with the brain. So what if the brain doesn't interpret what you see? Then you don't see it. That's what unfortunately happens, and this is what is called visual agnosia. So visual agnosia is inability to interpret, say, objects, places, faces, while the vision or the eye is intact. So it means that the brain is unable to interpret what the eyes see. So then we cannot consciously perceive an object, a place, or a face. So I will tell you a small story. I had this patient who actually came to us. His wife said, since yesterday he's not recognizing me.
Oh, that's a
my
serious
God.
problem.
So,
it is intentional, unintentional, you never know.
Well, one has to think both sides of the issue.
I agree.
But clinical examination revealed that there were certain neurological abnormalities as well. And this gentleman who was 65 years old also had diabetes and hypertension. So what happens is that there are connections of the brain to the visual system, which also help us to recognize. This is called the association area of the brain. So if there is a problem in the association area of the brain, one can't recognize, although one sees, even familiar faces. There's a term for this, it's called prosopagnosia. So what happened is we did an MRI of the brain, and we were actually able to show that there was a area of decreased blood supply in the area, which helps recognize faces.
Amazing.
So the gentleman was not lying. It was not a tiff with his wife. He actually could not recognize her or any other person he saw. Although he could see them, he could say that there is a person here, and he could describe them, but he could not say who they
Put
are.
the name to them. It's amazing because see, these I call these as software problems in the brain, which nobody understands. They only understand something is physically deformed and visible. They don't understand. So it's one of the easiest ways I tell people is if you go into WhatsApp and try to attach a video, till then you don't know whether that feature is working. WhatsApp may be working. That one feature may not be working. You go into Microsoft Word and you go to bold. It may not work, but Microsoft Word may be working. So no MRI scan, no CT scan tells us these things unless a clinician like you and me, who's informed about it, meticulously sits and dissects the the patient's brain circuit by circuit. Actually, it sounds like a surgery, circuit by circuit. You look at what is going on. Prosopagnosia is what you said. Visual agnosia is what we said. Let us introduce some more chaotic terms to them. What else happens in these association area problems in the brain? We'll come to the association area itself later, but just what problems happen. A couple of other stories to tell us to set the context.
Yes, I could tell you a few stories which will help us understand what are the problems which happen
Correct.
when association areas are in.
And then we'll find out why it happened and then we'll take the whole journey.
Correct.
Yes.
So what happens is basically the association areas are those areas of the brain where the information from the eye goes to the brain, and from there the visual cortex, it spreads to the other areas, which help in fine tuning and interpreting the data that is presented to the eyes. And disorders of these association areas result in various types of agnosias.
What does agnosia actually mean?
Agnosia means unable to interpret.
Perfect.
Despite the primary function being all right, like the eye can see, but the brain can't interrupt. That is called agnosia. That is a visual agnosia because the visual function of the eye is involved. There are different types of visual agnosias. I'll not go into the finer details, but a few stories.
Yes, give us a
So
few stories.
we had this patient who came to us, diabetic, hypertensive, and he was a designer.
Okay.
And he could not draw diagrams. That was his problem.
Crazy.
So we had to
Suddenly,
examine him. It
acute
happened
onset.
all of a sudden.
Huh.
When something happens all of a sudden, it's usually, the blood supply of the brain gets blocked. That is a stroke. It happens out of the blue.
Correct.
In fact, stroke, as described by Hippocrates, means bolt from the blue.
Bolt from the blue.
So that's how it happened. And when we actually checked, he could draw parts of the diagram, but not the whole diagram.
But I'm glad he reached out to you very quickly.
Correct.
Huh.
So it was impairing his work.
Correct.
And he knew something was wrong, but he was able to speak, he was able to read, otherwise communicate. There was no paralysis, but this was the problem. So this is a type of, what shall I say, perception problem called apperceptive visual agnosia, where people can't see the whole picture in the sense that they can't copy diagrams, they can't interpret objects. So things like that. There is another form of visual agnosia called associative.
What a tragedy, He could have had that anywhere else. He's being a designer. Of all the places the stroke could have happened, it has happened here.
Yes.
That's what you say, bad luck sometimes, at
Correct.
the end of the day.
Well, that happens sometimes, and it is our duty to try and, like you said, speak to the patient, try to understand. Then, unless the patient expresses themselves and the doctor listens, we are unable to, interpret what's happening.
Every patient's story has to be listened to,
Yes.
but told also.
Yes. Told is because, we would like other people with this kind of difficulty to approach a neurologist.
Correct. Absolutely.
Very often what happens, it is misinterpreted, and, they think it's a psychological problem and meet a mental health professional. So, it has to be heard well by a doctor to try and, understand what is going on with the patient, and then they're able to understand and, pinpoint what the problem is. So visual agnosia has got many such, there's this type of visual agnosia where you see the tree but not the forest. So you don't see the full picture. It happens in a condition where there are bilateral strokes. Stroke in both parts of the brain. So the part of the brain which controls vision is called the occipital lobe. It is in the back of the brain. So if there are
so
strokes,
far away, The
so
eye is in
far
the front,
away.
is at the
Yeah.
back. Why is there a design problem with God? Normally, God gives everything the closest, no? Why is it taking it so far?
This is called the older vision is a basic part of man's existence.
Correct.
Without vision, there is no man.
Excellent.
So we have a
Absolutely.
compound vision. So it is whereas the parts of the brain which are more forward are more related to thought and other processes, memory and other processes, which are believed to be higher functions than vision.
Got it.
So, vision is there even in a primate or in a lower form of animals. So, what happens is it gets relegated to the back embryologically as man is developed and thoughts and other things which make us a superior being.
Got it.
What happens is that there are several wires, the optic nerve, and we'll come to that later, which connect the eyes to the back of the brain. So when the back of the brain, there are clots happening in both sides of the brain, which sometimes happen. What happens is that a person can see only parts of a picture, can't see the whole picture. So you give him a picture of a forest, he sees only the tree in the center. It's not that the eyes are not seeing, the brain is unable to understand that the eyes are seeing the whole picture.
Got it.
Because
So-
some functions are not working.
Something is not. I think some of those lights are not lighting on. What is color agnosia?
So sometimes one of the visual functions is understanding color. So we see a curtain which is blue or a dress which is red. But what if you're able to see but not identify the color? It's like not recognizing the face, which we discussed.
It's something similar. The context is the
Yes.
same.
These are all different types of. But there is a more extreme form of
Huh.
color agnosia
Huh.
where the whole world looks gray. It's
Really?
called achromatopsia.
Correct. That's right.
That is also there. So the world
Mm.
looks grey, black and white.
So like the olden days before
Olden
the
days
color TV
movies.
came in, yeah, olden days movies and things like that. So guys, you can go to an olden days movie level if you have some problem there. So you gave us quite a strong introduction. So now the question the audience will be having is, here is a neurologist. And we are talking vision. And we are talking things about vision that none of you have heard of. I'm quite sure majority of you haven't even heard these words, forget about these symptoms. Or some of you had the symptoms, you don't know what's going on. So he is a neuro-ophthalmologist. That's his specialization apart from being a neurologist and an epileptologist. So Sujit, now we'll come to some sanity and ask a fundamental question. What is neuro-ophthalmology and what made you get into this as a subspecialty
It's a
of
very
neurology?
interesting question, sir.
Ah.
So very early in my training, I was interested in neuro-ophthalmology. What does neuro-ophthalmology comprise?
Mhm.
It comprises those disorders. I think I'll have to just tell some background.
Please.
The optic nerve is part of the brain. It's part of the central nervous system of the brain. So it develops and connects to the brain directly. So it's very different from other nerves. So disorders of the brain can very often involve the optic nerve, like multiple sclerosis, and we'll come to all those a little later.
Correct.
So the optic nerve and the brain are one and the same. So there are a lot of disorders where the optic nerve, which means the vision, and the brain are involved. So there are a lot of disorders which come under the canopy of neuro-ophthalmological disorders. So I think we talked about many interesting phenomena here. So I'm sure all of you must have found it very interesting. That is what enticed me to go into neuro-ophthalmology. And of course, there is the saying that more than 1,000 days of study is one great day with a good teacher. So I had a great teacher, not just a good teacher. His name was Professor Vivek Lal, who's now the director of PGI. Who's one of the
Director of PGI now? I
yeah,
didn't know that.
greatest neuro-ophthalmologists I've seen and worked under. And I was mentored by Professor Vivek Lal and encouraged to take up neuro-ophthalmology, which is, I think it's like the rest of neurology and neurosurgery, involves a lot more detection, which is what made me take up neurology in the first place.
Correct. I agree. No MRI shows you that. No
Yes.
CT, no blood test tells you that. It's fascinating. And no
Exactly.
two patients are the same.
Correct.
No two
Great.
patients.
And contrary to what people believe, the brain has a lot of plasticity. So a lot of recovery can occur from these disorders as well. You are the expert on that, Dr. Sharon,
Correct.
about rebooting the brain.
Absolutely.
So we need to understand the brain well
to reboot it. Yes, that's the fundamental truth. Elementary, Dr. Watson, is what Sherlock Holmes says.
Exactly.
So that's the fundamental truth.
So neuro-ophthalmology has always attracted me, and so I felt that there was a need. The number of people who do neuro-ophthalmology are very less. So when I moved down from PGI Chandigarh to Bangalore, we decided to establish a neuro-ophthalmology clinic and work with ophthalmologists trained in neuro-ophthalmology. So I do visit Narayana Nethralaya, where we see such complex disorders, work with very senior neuro-ophthalmologists like Professor Rohit Shetty, and it was his brainchild too to start a neuro-ophthalmology clinic. So with this, we see very complex disorders, and frankly, William Shakespeare always said, the eyes are, the index to your soul. So the eyes reveal a lot more. Eyes means the entire function of vision, a lot more about brain disorders. Many things can be identified by examination of the eyes, what we call neuro-ophthalmological examination.
We're going to catch you on all of the each. What are you going to see here? What are you going to see there?
Absolutely.
So now from this end, we'll go to this end. Okay, because that's where the story starts at the end of the day. So what? So let us understand the fundamental of the eye, the globe, the eyeball, and everything else. So there are certain things. I'm not going to talk about the lens and all of that. That's an eye doctor's business. So you have the optic nerve that you spoke about, and you also have two other words called the blind spot and the macula. I'm going to leave it to you now to start the way you want.
So what happens is, as doctors will know, I will make this very simple.
Correct.
There are nerve fibers which arise from the retina, which is the back of the eye. You have the lens in the middle, the cornea in the front, and the retina behind. From the retina, the nerve fibers arise.
So retina is
form.
like the screen on which
exactly
the image falls.
Exactly. It works exactly like a screen.
Yeah, correct.
So, and then the nerve fibers get stimulated and convey this information to the brain, which interprets the information in simple terms.
Correct.
So what happens is that the nerve fibers form the optic nerve. So there are in the retina various cells called rods and cones. These are called photoreceptors. The cones are very important for color vision, whereas rods are important for vision in dim light. So the cones are maximally concentrated in the center of the eye, which is called the macula. The center of the macula is called the fovea, where the visual acuity or the strength of vision is maximum.
Sharpest.
And just adjacent to that is where the nerve fibers leave the optic nerve, and here there is what we call a blind spot. So if you're in the blind spot, you don't see that. There's a very small area which is right next to the macula.
So in every meeting, especially in these management meetings, MBA, that's your blind spot, they say. So I'm quite sure most of you have heard it's your blind spot. So tell us where the original blind spot word came from and why is it called a blind spot?
Because the nerve fibers there are leaving the retina and there is no vision there. If light falls there, it is not interpreted. So in a particular test of the eyes, what we call visual fields, we actually see that the rest of the field is normal, but there is a dot which is to the, if you say, outer aspect or the temporal aspect, it's about 12 to 15 degrees temporal. So there is an area where, you can't see. It's a blind spot. It can be mapped also using visual fields. Even clinically, when a doctor examines a patient, it can be mapped, but it is normal. It's there for everybody. Only if the blind spot enlarges or something, it's abnormal. But otherwise, it's a normal thing for everybody. So everybody has a macula, a fovea, and a blind spot, and an optic nerve.
Got it. Now, we'll ask two more questions before we come to the pathology. Now, you also mentioned there's something called central vision, peripheral vision.
Yes.
Everybody knows vision. What is central, peripheral? How important is it? How critical is it from a neuro-ophthalmological perspective?
So both are very important. What happens is the central vision is the center of the vision, or the vision which is subserved by what I told, the macula, where the maximum receptors are there. So your sharpest vision is in the center of vision. Peripheral, you might see some vehicle coming from a distance, you see through your peripheral vision, but it's not as sharp. Then you turn around to look at it.
Correct.
So that you can see it from your fovea. So something in the periphery is not as sharp. The rods are more in the periphery. The cones are in the macula. So if the central vision is affected and the peripheral vision is spared, people will still find it very difficult to see things. Whereas if the peripheral vision is affected, as happens in some types of disorders, and the central vision is spared, people will still not realize they've lost vision.
I agree with you. So many come like that. Sometimes it's disastrous. So it's very interesting what you're saying, peripheral, central, and then you also mentioned something called visual field. I have this complaint, I did my first episode of the podcast was with Dr. Vikram Hudet. And we spoke about stroke, obviously. And he said, Doctor, all health checkup is done from here downwards. Nothing is done from neck and brain. It's a very neglected area. In the same way, routinely, ophthalmologists do not check the visual fields, is what I realized, until we write it. So why can't you, as a neuro-ophthalmologist, make it a standard of care so that like they check it, because it's so easy to check the
Well,
clinically.
it is supposed to be standard of care for every neurologist and
Really?
neuro-ophthalmologist and every ophthalmologist also, because it takes about a few minutes to check the central and visual fields without equipment, with just clinical
Yes,
examination.
yes.
So
So
very
easy.
often, very dangerous disorders can be detected,
Exactly.
like strokes, tumors, can be detected if there are field defects. I should tell you a story here. So we had this patient who was a little obese. He was only 35 years old. He'd been complaining of headache for the last 1 week, severe headache. I mean, he didn't meet us. He was meeting some local doctors. One fine day, he collapsed in his office, and then he was brought to the emergency. His blood pressure was only around 80/60,
Oh,
and he was not responding, unconscious.
okay.
And when we examined him, we found that he's unconscious, but he's moving all his four limbs.
Hmm.
Then when he got up, he woke up a few minutes later.
Hmm.
By the time we were trying to start an IV line and put some, then we did an examination. You know what was a strange thing?
Hmm.
He could see neither to the right nor to the left. He could see only
Straight.
straight. So this falls under a field defect. The temple, the temple, we call this a temporal half of the field. So both the temporal half of the fields were lost. Now, as a neurosurgeon, that's a very dangerous disorder.
Absolutely.
When you have bitemporal loss of field, or what we call bitemporal hemianopia, with a low BP, it means that there is a tumor in the pituitary. And the blood pressure dropping is because the adrenaline hormone drops, the cortisol drops. So what he had was a large pituitary tumor which arose from the pituitary gland. It was compressing. Behind the optic nerves there's an area called chiasma, which produces this characteristic defect, and that's why his blood pressure had dropped. But
Apoplexy. That's what we call it.
pituitary
Pituitary
apoplexy, that's what we call it. Timely intervention saved him, and his fields largely returned to normal after his tumor was resected.
So when I was studying to be a neurosurgeon, and I was reading all these books, Patton's book, he was talking about the hat pin to test the visual field.
Yes.
The white hat pin and the red hat pin,
Yes.
and how the red desaturation was the earliest sign of visual field loss.
Absolutely.
And I've always felt, why can't we catch it early versus somebody who's already had a constructed visual? That's because eventually, Sujit, at the end of the day, it's like buying an insurance after the accident. We can't promise everybody that the field will expand again because we are not sure about that fact, which is why the people have to test it very well.
So it's with nostalgia. I remember the red and white pins.
Yeah, without that, you can't go to the exam.
Which was part of my neurological kit.
Correct.
20 years back when I passed out from PGI Chandigarh. So we used it to measure the fields, especially the central field.
And you have to look at the red desaturation.
Exactly.
And it's amazing how it looks less red. It's that's how it is. So I think that's so. The two things he has said. He said the guy couldn't see on both sides. It's called bitemporal hemianopia. He used the word chiasm. So obviously people are wondering what the hell is this. So Sujit, I have a very fundamental question on behalf of everybody. I keep asking everybody this question. We have two eyes, but I see one Sujit. What is going on here? Is this by design? Where the hell is this business going on?
Correct. So insects have compound eyes. They see multiple things.
Correct.
Whereas we have what is called binocular stereoscopic vision. That is the term used.
Correct.
Both eyes fuse into one image in the brain.
Correct. The merger happens in the brain.
So how does that happen? It's a very nice question. So as I said, the eyes are connected by wires called nerves to the brain, to the back of the brain, which is called the occipital lobe. So you have the optic nerves. They go and meet at a junction called the chiasm, the optic chiasma. So here what happens is 50% of the eyes from the fibers from the right go to the left. You have, like I said, towards the temple, the temporal, towards the nose, nasal. So the nasal fibers cross over to the opposite side. So it is that each half of the brain can see from both the eyes.
You see how God has designed this. I've always been fascinated by the way, nature or God or whoever has constructed this. I was saying Dr. Dugani the same thing, and I've told so many people. The human body is designed for surgeons. I'm not nothing against you, but maybe you also. But for us, when we open, we are so clear about how the whole process happened. But it's so fascinating. I've always been, enamored, and also the binocular vision makes you see wider than what you would see with one
That's
eye.
what is the stereoscopic part.
Correct. That's the stereoscopy. Got it. That's right. So now you have the chiasm. You're saying 50% goes straight, 50% crosses, because of which you see half off on one side, half off on the other side. So you preserve whatever half that is there. And then it starts going backwards. We'll come to that a little later. So this whole area that we have now, starting with the retina and the optic nerve, the blind spot, up to the chiasm. So tell me what all in neuro-ophthalmology happens in this space that people should watch out for. What symptoms do they come? What should they do? What should they not do?
So after we have the optic tracts and read, I'll not go into the details, but see, it passes through to reach the occipital lobe. The radiation has to pass down through the temporal lobe and up through the parietal lobe. Correct. So here also, there can be strokes, tumors, and other things which interrupt this.
Which we'll come there. We'll do that part. I'm asking the front of the brain.
Oh, okay.
The front portion.
Okay.
The front portion from the retina to the chiasm. What all problems happen?
Oh, yeah. There are multiple disorders which occur.
Correct.
So since it is not, it crosses over in the chiasm. So usually, if an optic nerve is involved, you get disorders involving only one eye. So it's called a monoocular visual disturbance. So we have multiple disorders which can produce this. So you have disorders where antibodies are produced against the nerve. So the nerve is like a pen, the optic nerve. There is an axon in the center like the refill, and then you have a myelin sheath like the plastic cover of a pen. So some disorders are there where antibodies are produced against the myelin sheath and damage the optic nerve.
So let me interrupt you and ask, what is antibodies for the sake of our audience who don't
So what happens
antibodies?
is normally when our body develops an infection, say from a virus, the blood cells produce something called antibodies which fight against the virus or the bacteria and defeat them and cure the body. But sometimes there can be disorders in immunity wherein these antibodies attack the body's own cells. So you must have heard of arthritis. Rheumatoid arthritis occurs because antibodies attack the cartilage in the joints. So optic neuritis or inflammation of the optic nerve occurs because the antibodies attack the myelin sheath which covers the nerve, producing decreased vision or blindness in severe cases.
So how do they present? What's the normal classical? See, anybody can have decreased vision. Even something falls in the eye, they don't see well. Some cataract problem, they don't see well. If I remove my specs, I can't see well. It's things like. So when should they press the red button and go? So can you?
So I'll start with the history. There's a patient which I saw yesterday. So there was this young lady who was 15 years old.
15
years old. Very young.
So that means this can happen in any age.
At any age. Generally younger individuals.
Okay.
Are the inflammation is more common from about 10 to 30 years of age.
Got it.
So she came with a history of sudden onset over a period of few hours, not like the stroke which happens in 1 minute, a few hours. There was decreased vision in the right eye associated with pain on eye movements. Pain on eye movements,
the eyeball
decreased
is
vision, and over a period of 1 day, by evening, it became worse and she couldn't see properly. So this is a classical history they come with.
Okay.
So for a period of 1 or 2 days, a decreased vision, painful eye movements, and when we examine...
But no fever.
No fever.
Okay.
But rarely fever can precede. Like I said, you have a viral infection,
Correct.
antibodies produced against the virus. So fever can precede what we call an optic neuritis.
Got it.
And there are some disorders where this kind of disordered immunity occurs recurrently, like in multiple sclerosis, MS or neuromyelitis optica, some disorders in which. So it is important to diagnose optic neuritis, also find out what is the cause, whether it is just due to viral infection, what we call post-infectious, or is it likely to be a recurrent form of optic neuritis, in which case some medicines have to be given to prevent further recurrences as well.
So, the two things that you're telling me right now, you're telling me when the patient comes for the first time, we don't know it is a one-off episode or it could happen again. Now, that's one part of the story. Now I'm going to come to the more fundamental part on behalf of the audience. Something has happened already. Forget about the recurrence. Can I get my vision back?
Absolutely.
Is a question. So can you
For-
tell us
it is-
how quickly they have to act for that and how
So
critical it is?
as early as possible, if there's a vision loss with painful eye movements, one has to approach a neurologist. If optic neuritis is
So
identified,
if it happens at 12 o'clock in the night, should they wait till morning?
they can come immediately.
Yes.
I would recommend coming immediately, because the
Correct.
earlier the treatment is started, the better.
So please remember that. Even if it's middle of the night, you guys have to come to the hospital.
And we give an injection called methylprednisolone, which reverses the autoimmunity and restores vision. Generally, in a week or 2 weeks, it becomes completely normal.
Good.
So,
So there's
you
hope
know,
in that.
somebody who has no vision becomes normal. That's a very gratifying experience.
I agree. It's from, hopelessness to hope, from depression to elation, that's what is
You
going to
said
happen.
no. Tamasoma Jyotirgamaya.
Exactly.
That's exactly.
Absolutely. That's why
From
I say,
darkness to light.
yes, that's what I'm saying. Today is so appropriate. But what I'm saying is, every episode, I learn so much from every guest who comes in, though I'm from the same field. All of us don't know everything about everything at the end of the day. So you are giving two informations now for the people who have what is called optic neuritis. That means, one, if I intervene in time, even if you really can't see, you can get back full vision. And number two, parallelly, he has to make sure that he investigates further to see whether this can happen again. And why is that important, Sujit? Okay, I can't better, chalo, let's leave it alone.
So what happens is, sometimes those disorders which produce recurrent optic neuritis, as in by recurrent, what I mean again and again. So what happens is, each time the optic neuritis occurs, the recovery is not complete. If it is in the same eye, second time, third time. So it's better to prevent it from happening.
The vision starts coming down. Got it. And let us say, if suppose you are dealing with some type of a repeatable problem, like you called as MS or neuromyelitis optica, will it always affect the same eye, or it can affect the opposite eye also?
Well, it can affect the opposite eye, and in our neuromyelitis optica, sometimes both eyes together. So it's seen that as well.
Oh, so
that means I have to tell you another story. I'm
Sure.
sorry, I'm very fond of telling stories.
We want you to tell stories, because that's the
because
best
these
way.
are things which we see in everyday life.
Exactly.
And for us, right now, it's a story which educates others. But for a patient, it was restoration of health and sight.
Absolutely.
So we had this young lady who came to us from Tumkur. I'm not mentioning names. And she had complete loss of vision, both eyes. Couldn't see even light. Happened over one day. And then she met a local doctor who said, there's some swelling of your nerve. We're not sure what it is. Go to Bangalore. So we saw the patient. It was a bilateral, optic neuritis involving both eyes. And we started treatment. The vision was restored in both eyes. And we found out that it is a recurrent form of optic neuritis, what we call neuromyelitis optica. And subsequently, after treatment, which has been continuing for 2 years, there's no further episodes.
And vision is normal.
Vision is normal, completely normal, because we've assisted with fields and all that. So for this patient, it was like, Jyotirgamaya only.
I know.
With zero hope she came.
Correct.
She thought she'd lost vision completely, recovered completely, which is the importance of recognizing these things and taking help at an early stage.
Come to the right specialist, so the right thing is done at time. Everything is timing and the appropriate intervention. So that automatically, so what you are saying, this both eyes, one eye, monocular. So the next automatic question is, how is the diagnosis made? Do I look inside the eye to diagnose? Do I do an MRI scan to diagnose? Is there a special scan? Can it be missed by this one? What is the risk of missing if I go to the wrong place, especially in the periphery? If they're not in Bangalore city, there's some Tiptur, somewhere the Gadag, Gidak, or anywhere else in Karnataka.
So there are ways of diagnosing clinically. There are some, what we call as a doctor, symptoms of what the patient comes with, signs of what the doctor elicits. So there are some signs in the eye, in the pupil. When we look into the eye with an ophthalmoscope, some signs are there which helped us to diagnose. But to confirm the diagnosis, we use some tests also. You were just mentioning MRI scan. So we do a special scan of the MRI, brain and orbit. Orbit is, where the eye is encased, the bony socket in which. So we do a MRI of the optic nerve, and that shows a bright signal. In simple terms, a bright signal. Now, there are different causes of optic neuritis which involve different extents of the optic nerve. So, if it's a post-infectious optic neuritis or an MS, it's a very short segment, less than 50% of the length of the nerve. If it's more than 50%, sometimes involving the chiasma, which I mentioned, it could be the recurrent, more dangerous form, which we call neuromyelitis optica. And then there are some blood tests, and we also do a spinal tap to identify certain, what is called oligoclonal bands. But like I said, with treatment, most of the patients can recover completely.
You said a very important thing that you have to do MRI not just of the brain but also of the orbits and specifically of the optic nerve.
Yes.
Now, this is where the problem is because they go to a place or to a doctor who's not well versed in this. They just do a routine MRI brain and it can get missed.
Absolutely, sir.
And have you seen situations where they've done this MRI scan normal, like a patient is going like a football between the eye doctor and the, going on like this? Has that happened?
Many times. What happens is that the imaging or the MRI of the orbit, there are some special considerations while doing it, which a radiologist who's experienced in that can do it properly. Whereas in the periphery and all, many times an MRI is done routinely without giving emphasis. And of course, it's the duty of the doctor to tell the radiologist what to look for.
And many times the radiologist is sitting somewhere else, is remote. So, the whole gap between this and that, no interaction. So, guys, what we are trying to tell you is, it's very clear, important for us for the right hand to know what the left hand is doing and so on and so forth. So, it's good to overreact than underreact because you may not get a second chance. Last week I was having an online meeting with some senior academicians and scientists from a university in Kerala. And just to drive the point home of how abysmally low the knowledge of neuroscience is to them, I asked that Vice Chancellor a question. Sir, are you aware of what is a stroke ready hospital? He said, Dr. Sharan, I'm hearing it for the first time. So it's like that. So stroke itself, they don't know. Now you're talking neuromyelitis optica, optic neuritis, vision loss, MRI of this. So there's so much to know in neuroscience. That's why we are doing all these episodes. So the length of the optic nerve, the effect is there's nothing. Do they have to do a contrast scan or plain scan is good?
So ideally
enough?
a contrast has to be done.
Okay, what do you look extra in the contrast?
So the contrast will show. See, what happens is in the brain there is something called a blood-brain barrier.
Correct.
Which in normal cases the contrast which is in the blood cannot enter the brain. Optic nerve is part of the brain. So whereas if there is an optic neuritis, there are gaps in the blood-brain barrier because of the inflammation. The contrast enters the optic nerve and you see it brightly enhancing.
So that also is adds to your diagnosis.
So,
got it. So now there's another condition which goes with the optic neuritis called retrobulbar neuritis. Now, what is the difference between optic neuritis and retrobulbar neuritis, and why is it important to know both?
So optic neuritis ideally is of two types. What you have papillitis, which is the front of the optic nerve, which we are able to see with a scope, and the back of the optic nerve is called retrobulbar neuritis, which sometimes may not show anything on examination. Other than the pupillary defect, it will not show anything. So an MRI will reveal it. So sometimes especially in NMO, you can have the back of the optic nerve which extends up to the chiasma involved, in which case we call it a retrobulbar neuritis.
Why I'm asking this question is there's a high risk that they'll go to the ophthalmologist who's probably not aware, a new guy trained somewhere. He looks at puts the fundus, looks at it, it looks normal. He may treat as something else for a day or two to observe, because even a day or two for us is risky. So MRI scan definitely has to be done. Anybody who's got an acute onset of vision problem.
Yes, it should be done. And ideally what happens when there is a decreased vision and the optic nerve fundus is normal, it's indicative of retrobulbar neuritis.
Until proved otherwise,
senior people, ophthalmologists will pick it up. But in case one doesn't, it's important to get a scan done in such case.
So we know, but I just come, the reason is I'm not saying ABC, but come to make you guys understand that just because A didn't pick it up, don't say, you have to also be equally informed about what is happening, because you can't afford to lose the vision in the eye. So we always say that, the retina is the only part of the brain visible to the naked eye that you can see through the scope, obviously. So this beautiful tool we have, the ophthalmoscope, all of us use it, not just the ophthalmologist. So what all would you see and what all would you interpret as a neuro-ophthalmologist when you look inside the eye?
A lot of information is given. So what happens is one looks at the retina, which is what we described as a screen where the images fall. And then we see the optic nerve disc, which is where the optic nerve emerges from the retina. We can see the macula as well as the blind spot. So this gives us whether the optic nerve is healthy. So if the optic nerve is healthy, we see the cup in the center and it does not become pale. If it's pale, if it is extremely red, it means it is unhealthy. Also, the retina can be affected by disorders like diabetes and hypertension, where a lot of changes can occur. So the eyes reveal a lot if you examine them. So it's not only the retina, but there are changes within the pupil which occur in optic neuritis, in other disorders of the optic nerve, and the other nerves which we will cover later. There are a lot of changes which can be seen, and again in the fields, in the pupil. All these put together give us a lot of information.
So you already have a reasonable hypothesis built up between the history and the examination, and based on that you can choose what all set of tests to be done, so that you get the whole picture, so that the treatment can be more comprehensive. Okay, so that's the fundamental communication you say. So you said two things right now. You said about the disc and you said about the pupil. Let's start with the disc first. So there's something called papilledema that we talk about. And as a neurosurgeon, we always say papilledema means brain pressure is high and all. So can you tell us what are the different things that you will see in the pupil that makes you press the red button, and it's a warning sign that something should not be neglected?
So I was just telling you what we see normally. We see the optic nerve and we see the cup in the disc.
Correct.
So what happens is, if there is a swelling in the disc, we call it disc edema or papilledema. This occurs because of there's a fluid in the brain called cerebrospinal fluid. It circulates around the brain and acts as a shock absorber to the brain and the spinal cord. So when the pressure of the fluid increases due to whatever reason, there could be a tumor in the brain or the fluid increases in amount, whatever, it shows as a swelling in the eye. It means that the pressure is, it transmits along. So the coverings of the brain are the same as the optic nerve. So the fluid circulates around the optic nerve. The pressure of the fluid is raised due to any reason, either a clot, a tumor, or just increase in the amount of fluid. It can cause papilledema.
And then you see it there.
Then we have to do other tests to find out what is the cause of the papilledema.
Correct. So can there be a false positive situation where the pressure can be high but the papilledema can still not be seen?
Absolutely. One must think of all these things.
Correct.
But those are rarer. Generally, if the pressure is high, papilledema is seen. Rarely what happens is that if the attachment to the meninges are the coverings of the brain, if the attachment to the optic nerve is very tight, it may not expand enough to show the raised pressure visible in the eye. But it doesn't mean that the raised pressure is not there.
Exactly.
So a scan will reveal that.
Yes, that means the scan is a must, even if the papilledema is not seen, if the suspicion clinically is high.
Exactly.
So that, and then just as an extension of what you said about the retina, if you have a central retinal artery thrombose and then the retina becomes pale, and then you look at that, and that also you can get an extension of.
Correct.
So coming to the pupil, what is this pupil and what is this reaction? I mean, it's a favorite question for neurosurgeons all the time, or neurologists.
Correct.
So,
but as far as the public are aware, you must remember that the pupil it controls the amount of light which goes into the eye.
So what is the pupil if somebody who really doesn't know anything?
So in the eye, we have something called a circular structure called iris. That is what gives the color to the eye. You can have a brown iris, you can have a black iris, you can have blue eyes. Many Westerners have, that's a blue iris. So in the center,
now everybody knows some of the phones do an iris scan.
Yes.
So
the iris has got some markings on it which can be scanned. So it's an iris scan. So the center of the iris, there is an aperture or a hole in the center. Iris is a muscular organ. So when the iris contracts, the pupil can become small.
The small,
it can
round
expand
in the
also.
Center of the eye.
Yeah, it can expand also. So the hole becomes bigger. So this hole, what we
like
call
the aperture of a camera.
Exactly. It's a very good analogy, because it works like the aperture of a camera. If the light is too much, the pupil will constrict or become smaller. If the light is dim, the pupil will become larger to allow more light to come in. So it works exactly like a camera, so that the image can be captured on the retina.
Perfect. So what is this pupil and reaction all about?
So when
you said pupil reaction comes down.
When bright light is, when a torch or a source of bright light is put on the pupil, it constricts. This is called the light reaction.
It becomes
Pupil
smaller.
it becomes smaller. Exactly. And because the connections between the pupils, the opposite eye, which does not receive the light, also constricts. That's called the consensual light reflex. So this is something which, if it is not there, it means there's a problem. If the pupil doesn't become smaller to light, it means there's a problem.
It's a problem. There's a problem in the light getting transmitted because of the
Exactly.
optic nerve issue, and that's how
Exactly.
indirectly you're understanding what's going on.
So that is what we meant, that those are some clinical signs of optic neuritis and other disorders where the pupil tends to get involved.
Perfect. So, there's a statement that we always read in medicine and everywhere else: what the brain does not know, the eyes can't see. So, unless you have asked all these questions, right, the right requests on the MRI, people can miss, something that's even though the patient went into the machine. So now we spoke about the pupils, the papillary. So what happens to if the papillary edema is left untreated, or if it lasts for too long? What is the effect? Does it have a bad effect on the vision and the eye and everything else?
Absolutely. When the pressure is more, when the swelling around the optic nerve is more, the fluid tends to press on the optic nerve. And as the fluid presses on the optic nerve shrinks in size, what we call atrophy, and that affects vision. So it's typically like what you said, the peripheral fields are first involved. There occurs a reduction in the peripheral field until the patient has only a tunnel vision.
Oh, just like this.
Like a tunnel. And then finally the tunnel also closes. That's what happens if it is untreated. We've seen it sometimes in rural folk who ignore headaches and blurring of vision and all that. And then, finally when they come, it's too late.
Too late. And you can't reverse it all the
You
time.
can't reverse it once a significant portion of the optic nerve is damaged.
So let's now reach the chiasm. The two eye nerves coming in there, and then they join together. You said 50-50, all of those things. So what happens in and around the chiasm area that the neuro-ophthalmologist commonly see? You did mention the pituitary.
Yes, the
but good
pituitary
to
is the
talk about
most
it a little bit,
important,
yeah.
and I think you must have seen a large number of these cases, more than me, because
Yes.
you're a neurosurgeon who
Yes.
actually operates
Yes,
those cases.
yes, absolutely.
So very often when there are tumors, either coming from the pituitary below or from above, from the hypothalamus, it can cause compression of the chiasma and produce what we call a bitemporal defect. Sometimes the tumor can be little more forward. So one eye gets affected and the other eye gets affected partially. That is called a junctional scotoma. So these are the disorders. And also, some of the optic neuritis can extend backwards and involve the chiasma.
The NMO spectrum,
NMO.
you said.
And one rare cause which I should mention is that we see it quite often.
Mhm.
So anti-tubercular drugs, I'm sure you must have come across many patients. Rarely one of the drugs is known to affect the eye and cause ethambutol is known to affect the eye and causes a toxic retinopathy.
I'll tell you why I'm smiling. 1999, I was in my final year neurosurgery. 6 months before my exam, I developed tubercular lymphadenopathy. Okay, and so I was put on AK84, which included ethambutol. So everybody said, better check, color vision and all of those things. So like a good boy, I went to the ophthalmologist and they opened the Ishihara chart, and they said, that's when I officially realized I was colorblind. And I was saying what I was saying, and the ophthalmologist looking at me, are you sure? I said, yeah. He said, Doc, you're colorblind. I said, I was struggling with matching colors, but I never knew. I would say casually, but I didn't know officially. I would make the classical mistakes on the Ishihara chart. So that became very stressful for me. I did take the ethambutol, but now I'm already colorblind. So what is going to happen? So I understand very clearly how you put it, checking that baseline was for ethambutol. But anyway, so however rare it is. So, there are people who don't see, vehicles coming on either side. There are people gone caused accidents without realizing what's going on. Many of them got multiple accidents before they even got realized that there's some problem with my peripheral vision. It is crazy, how it can go on, undetected because there's no headache, there's no pain. Somehow, I think when you have pain, people come faster than when there's no pain. I think that's the fundamental, the cause of what is going on. Good. So we have covered so far. So let us go backwards from the chiasm till the occipital cortex, which is the V1. You've already mentioned that. So tell us this story now. So what happens? These half fellows are crossed, half fellows are done. Then what happens to that optic system?
So, you have the optic radiation,
Okay.
which is part of the, as it goes into the brain. So as we know, optic radiation goes above through the parietal lobe, the
Correct.
occipital lobe, and
Correct.
below through the temporal
It
lobe.
goes like that. Yeah.
So as we know, in vision, if the part above is affected, it causes a defect below in the visual field because that's how it reflects. And if the radiation below is affected, it causes a defect above. So what we see is if the optic radiation is involved in the parietal lobe, they have difficulty looking down, what we call a pie in the floor. It's like a pie, in your vision, which you can't see. It looks like a pie. And if the temporal lobe, the optic radiation is affected, it looks like a pie in the sky.
In the sky.
So you can't see above, the
Pie
quadrant
in the
above.
sky, pie in the floor.
Yeah. Very interesting terms, but very often patients come to you, and it happens suddenly. If they had a stroke, they say, Doc, I can't see. When I look to the left, I can't see. So, the right temporal lobe, right parietal lobe is involved. And then when you do an MRI, it comes out. So listening to the patient's history is very often. And sometimes I've seen people complaining of these things and not diagnosed for a year. And finally they come to us and then we are able to pick it up. But this happened 1 year back. And he's been complaining, but nobody is bothered about it.
I know. It's
That
like,
happens sometimes.
It's like Oliver Sacks, Dr. Oliver Sacks, a neurologist who's written a book called The Man Who Mistook His Wife for a Hat.
Yeah.
That's the
famous
book.
one,
Yeah,
yes.
it's a famous book that he's written to say how it is. So, the recognition problem and all of that. So before I realized that I didn't ask you one question from the front. You mentioned the word scotoma. I want to ask you, what is a scotoma? Scotoma. Scotoma means what? A lot of new words we are
Yes,
saying, so
yes.
for the sake of the
So
audience.
scotoma means defect in the visual field.
Okay.
So the central vision is affected, we call it a central scotoma. Peripheral vision is affected, it can be peripheral scotoma. Now there is something in the eye. We briefly talked about it. You talked about the central retinal artery. But if one of the major arteries are involved, it can affect a whole half of vision, superior or inferior. So this is called an altitudinal scotoma. So the superior part of the optic nerve is affected. It causes an inferior altitudinal scotoma.
Reverse.
This happens in people of diabetes, hypertension, who are obese. The blood supply to the nerve gets damaged because of a clot, and then it produces this. So one must remember that, and you told me in the chiasm it is a bitemporal. So you have the rule of the meridian. When the eye is involved, it's a horizontal meridian. Beyond the chiasma, it's a vertical meridian.
Correct.
So
got it. So I was going to ask you a natural next question. You said central scotoma, peripheral scotoma, altitudinal field defect. Then you said pie in the sky, pie on the floor. How are these two pies different from a scotoma? In the sense, the patient symptom, will they give the complaint differently? They give the same. You diagnose it. How does it work?
So what happens with an altitudinal scotoma is they're aware of it immediately because they can't see below or above, both eyes. Whereas what happens with a pie in the floor and pie in the sky, it's only a quadrant which is affected. So they may complain, but they may get by also.
Because
which is why you don't, sometimes you miss the doctor they go to, if it's a peripheral practitioner who's not very experienced with scotomas, may miss it.
So you also mentioned something called transient blurring of vision.
So transient loss of vision is very important because it can be due to ominous causes or due to simple causes.
What is a transient loss of vision mean? Can you tell it in English?
Yes. So transient means temporary. So you can have a temporary loss of vision. Depending on the type of loss of vision, one can decide what causes it. Now, what is
It's
the
a loss? It's fully off, or it can be at shades.
That's exactly. Now there is a condition where you have a complete loss of vision in one eye, which lasts for a few minutes and improves. Complete loss is usually ominous because it means the blood supply to the eye has been blocked temporarily and then released. This is called a transient ischemic attack, and it means that the blood vessel which arises in the neck is likely to be blocked, and this could be
It's like a
sign
stroke
of
of the eye now.
impending stroke. Sign of impending stroke. Yeah, it's like a stroke of the eye. Absolutely, sir. Well said. Then you can have a very simple. I'll give you the experience of a famous writer called Lashley who described migraine scotomas. So what happened was while he was walking, he suddenly noticed that the center of his vision, he couldn't see anything, and there were brightly flashing lights around it. This is called a scintillating scotoma. And then it disappeared after some time.
Like a disco light.
Disco lights.
Huh.
And then after some time it disappeared and he got a severe headache. So this can happen with migraine too. This is called a visual aura of migraine. So In fact, people are able to draw their auras on paper.
Oh, I didn't know this. Really?
They draw the scotoma and lights. Somebody, in fact, I think even nicknamed it as fortification spectrum because it looked like the lights on a fort coming on. So
that much of detail they
a
could
lot
draw?
of people, yes, absolutely.
Amazing.
It's
I should
because
next time I should ask my patient to draw.
people who are driving suddenly develop this scotoma and they develop headache after that. So they actually pull over and then they describe the symptoms. So I can see this round, defect in my field, and there are flashing lights all around it. So this is something which happens with migraine. Rarely, when we talked about papilledema, one of the symptoms that people have with papilledema is a blurring, not a complete loss, a blurring of vision in one or both eyes, which recovers. This is because of the pulsation of the fluid, which is more, causing the blurring of vision. So there are 3-4 different causes, but if it's a complete loss of vision, one must look into it immediately. Perhaps better to meet for all three because all three are disorders.
Correct. It's good to overreact because, not worth losing even one part of vision because we are so visually heavily dependent, we human beings. It can be quite disastrous, whether it's on riding, driving, operating, writing, whatever it is at the end of the day. So, what is the optic tract now before we go to the optic radiation?
Okay, we did talk about the optic radiation. The optic tract is basically from the chiasma, there is a connection to what is called the lateral geniculate body. I'm talking all technical stuff.
We just want people to know because
it is basically a mass of nerves, a wire, which goes from the chiasma to the geniculate body. And then from the geniculate body, there's another wire which goes to the brain.
So it's not one nerve going all the way from this end to that end.
There are junctions.
There are junctions which very strategically made by nature, God, whatever you call it. Each of it is a reason for making it. There's a layers in that. We're not going to all of that. It's a 6-layer LGB. We call it lateral geniculate body, but it has all its own stuff. Lamellae, it's not important, but you have to know this. So why is it important for me is the macular sparing and macular not sparing if you look at that.
Correct.
So I think the macula is the central sharp vision he was talking about. So when you have a visual field defect going backwards, so this changes from whether it's pre-LGB or post-LGB. So can you tell us a little bit about so he said till the chiasm, one eye gets involved. At the chiasm, both eyes get involved, but only the outside portion or little bit of a tera-mera like this. But once it goes behind, it's 1/2 of the visual field, the right visual. So can you explain that to us?
Yes, the point is well taken, sir. So if the optic tract gets involved, there is a complete loss of vision without any sparing of the center.
It's a line like this.
It's a line like that because all the fibers are affected together. Beyond the lateral geniculate body, what happens is that the fibers which go to the occipital pole, which is the tip of the occipital lobe, those fibers are supplied by a different blood vessel.
Correct.
So in a stroke, when the posterior cerebral artery is involved, those fibers are spared.
Escape.
So patient who will have a little bit of central vision remaining, which is God's way of protecting them.
That's what I'm saying. So amazing how nature, God has given all these safety mechanisms to do that. Which means that if you look at the center, let's say a video screen of your phone, if the macula is affected, you will only see half. But others you are able to see that, but rest of it is all 1/2 you can see, 1/2 you cannot see.
Now I want to tell you another story.
Sure.
So we had this elderly lady who came to us. She said she can't see anything. Both sides. And then she came we couldn't do the fields, which was not very cooperative. So what we did is we did an MRI. And we found that the tip of the occipital lobe is on both the sides are involved. Only the tip. The entire occipital lobe is free.
Really?
And then we did a field. So instead of macular sparing, patient had only macular involvement. So only those fibers which supported the central vision were
But bilateral, both sides.
Bilateral, both sides. So patient had a clot coming from, what we call the basilar artery into.
Oh, what a tragedy!
So so those fibers were
debilitating,
debilitating. So when we did the field, the entire peripheral field was normal, and only the central field was affected. But the patient was devastated because she couldn't see. After a few months, it started improving a bit, and she was able to navigate without bumping into objects. So sometimes the crucial fibers are also important.
Absolutely. It's not about the size of the infarct, the location of the infarct, which can be quite disastrous or not disastrous. So can these fibers? I have a story to tell actually. This was a story of a high court lawyer,
It's
and for 6 months before he came to us, he had 17 accidents all to the right side of his car. 17, 1 7. He would brush people, hit people, but lawyer, nobody paid attention. He just said, then he would argue in the court holding a paper like this. Instead that he would start holding the paper here. Nobody realized why he was doing that. One fine day he woke in the morning at home and he had an epileptic fit and became unconscious. He was brought in a semi-conscious state to the emergency, and then we realized he had a left side weakness, blah blah blah. And then we went and did a scan, and he had a large cancerous brain tumor in that area of the brain, which had caught the optic radiation.
correct.
And then we operated all he never survived, he never recovered, and he died. So this is how, different causes is not just a stroke that you're
Correct,
saying.
correct,
What
absolutely.
other things can cause these symptoms to come? Is it a harbinger of what all different kinds of things? You said about
Yes.
optic neuritis and this
Yes.
one. What happens as you go more behind? What
As we
else can
go
happen?
more behind, it is the disorders of the brain which cause. So, like you said, tumors, very common.
Mhm.
Sometimes accidents can cause. They can cause bleeding in the brain and affect the vision. So, notice here I'm saying bleeding in the brain. The eyes are completely normal. So
Yet they can't see.
we have seen many patients with, occipital lobe contusions who can't see. Contusion means, bleeding due to injury. So it can be due to stroke. So, and as we said, tumors. So rarely we've seen this. I need to tell you the story. We had this young lady who was being treated for a psychiatric illness. Her main complaint is she gets headache and she can't see properly on one side. That's all. But they thought that she's very anxious and she's put on medicine. Finally, she said, I want to meet an eye doctor. I think there's something wrong. And when we saw her, she had a classical hemianopia. Hemianopia means she couldn't see, say, the left side of the vision was completely affected on one side and the right nasal was affected. We found a large mass in the right side of the brain due to tuberculosis. It's completely cured with medicines. And we stopped all our psychiatric medicines. But because it had been there for a long time, some amount of vision remained affected. Unfortunately. But she recovered most of her vision.
God.
So there are even infectious causes which can produce.
Cause yes, tuberculosis or any of those. So it's amazing that, which means you're again reiterating that scans are important. Plain and contrast scans are important. Reaching the right doctor is important. Getting to the bottom of it becomes important because significant number of them can be reversed, which is not, which itself is a, big boon, because many times, once it has happened, it's done. There's nothing that you can do, but it's possible for it to reverse it. So we are going backwards, we are now hitting the brain called the cortex.
So
Yeah.
I need to tell something.
Sure.
We've been always talking about one side of the brain being involved with a stroke. What
Hmm.
happens when both sides of the brain are involved? Sometimes big clots go in and affect both sides of the brain.
Okay.
Let me tell you a small history.
Sure.
There was one of these, this is a very classical kind of presentation. We had an elderly man who was diabetic hypertensive. And then one fine day, like your lawyer, he started banging into things on both sides, not just one side.
Okay. Ah.
He started banging into things on both sides, but he would claim that I can see very well. And
refusing to say he couldn't see.
refusing to say he couldn't see. And then if his son or somebody asks, what is that? He'll imagine and tell something. Is that a cup? What is it? No, he'll say that's a table. Or it's a pen, something else. So then when we examined him, this is called confabulation. When you can't see, you make up things.
You make up a story.
And he genuinely believes he can see, but he's not able to interpret anything.
But why is that happening?
So there are areas of the brain which can't interpret, although the eyes can see. And when it happens both sides, this is called Anton syndrome, where it is actually a form of blindness which involves the brain called cortical blindness. And there is denial of blindness.
Denial of blindness.
Denial of blindness.
I was just going to say that. Denial. So he's denying that. So how do you convince that guy that you have a problem and you have to do something? Is it possible? Not possible?
It's difficult, but you can tell him that there seems to be a problem. You should not tell him that he can't see at all. There might be a problem with your vision, so you have to be more careful. And then you can say that this has happened because of a stroke, so it's likely to improve to some extent with treatment. So we'll have to convince them like that.
So you're saying that these symptoms, that the vision part of the symptom, is it the E part of the B fast so that they can also be thrombolized? Is that important for
Yes,
them to know?
absolutely. They can
So,
be thrombolized.
so
And if it's a big clot, you can actually go in and remove it. I'm sure you must have covered it with Dr. Vikram, who did.
yes, but you can say it again so that in the
So, well,
context
what
of that, I
happens
think you
is
can
that
explain both B fast and this in the context of vision.
So B fast is what, those it represents symptoms which occur, which should be recognized as a stroke, and it means that the person who's suffering from either hand weakness, balance, visual disturbances, they should immediately approach a stroke ready hospital, because this could be because of a stroke. And every minute millions of neurons are being lost. So the quicker we intervene, either with an IV thrombolysis or
Clot
a
busting, they can dissolve the
clot
clot
busting,
with the
they go in.
medicine.
The injection is given, which breaks open the clot, or in bigger strokes, where bigger vessels are there, the doctor who's trained to be an interventional neurologist or neuroradiologist can actually, like in a heart attack, you go through the blood vessel using a
Angiogram,
pipe,
as
an
an
angiogram, using a pipe, a catheter, which will actually suck out the thrombus and sometimes stent the vessel,
They go from
thereby
the
reversing it.
They go from here, go all the way to the brain and suck it out. So all that is possible. But
All that is
reaching-
possible, but it has to be done as early as possible.
Exactly. So time is brain, reach on time. That's very important to understand. Now you just mentioned Anton syndrome. It's a syndrome that you don't have to worry about that. But you also mentioned a word that when we were chatting offline called blind sight. Is Anton syndrome the same as blind sight, or is that different?
So blind sight is a syndrome or a feature that we see when both sides are involved. They may or may not have Anton syndrome. I'll give you an example. So I had this patient who said, "Doc, I can't see anything." It happened suddenly, and then we found he had strokes in both sides of the brain. But then we did a small experiment.
So walking around.
So
this is the problem. Most people think stroke is one side, you can't walk, you can't move. But here is a guy who's walking around, but only those
He
nerves
can't
are
see.
affected.
So what we did is we brought in 10 objects in front of him and asked him, what is this, what is this, what is this, what is this, what is this? 6 out of 10 he identified, although he said he couldn't see it. This is called blind sight. What it means, I mean, it sounds strange, but what does it mean? It means
It's an oxymoron, blind and sight. It's an oxymoron, huh?
The oxymoron. The eyes are actually seeing all the objects. The brain is able to interpret some of them.
That's what the first video said. He said, I can identify my child's face, but I can't identify the object because two different sets are involved. So that's because two different circuits are affected. Interesting. So that's blind sight. So that is something that I had not heard. So it was an interesting new word phrase for me, an oxymoron. So all this time, Sujit, we were talking about the negative aspect, something missing, something not working, some hole in the field, pie in the sky, pie on the floor. They're all negative phenomena. You also casually mentioned a scintillating scotoma, which is a positive phenomenon. So can you talk about a little bit of the positive visual phenomena that can also happen in patients, and how do you interpret that, and why is that important?
Positive phenomena can happen, like I said, in migraine it can happen. So you can also have different types of positive phenomena. So you have something called visual hallucinations. So
can you give an example?
So visual hallucination is you see somebody who's not there, or you
not
see
there,
who's not there. That's why it's called a hallucination. So I have patients who have there's a disorder called Alzheimer's disease, where people lose their memory and various other cognitive functions, memory, how they find way geographically, many things are lost in that, unable to calculate. So some of these people also have positive phenomena called hallucinations, where they see things which are not there. They say that I can see a person is coming and talking to me. They can actually describe the person when he's not there. These are positive phenomena which come from the visual association areas called visual hallucinations. Now, visual hallucinations are of two types. You can have unformed, some vague, bright object, or formed. There's a fellow wearing the shirt, pant, and coming and talking to me.
You can clearly describe
Clearly.
that. Correct.
So, again, there is, formed or come from certain parts. So I'll not go into the detail. Unformed come from certain other parts.
They're all part of the same visual circuit that
visual
happens.
circuit, exactly.
So if you irritate it, you get positive phenomena. It gets damaged, you get negative phenomena.
Usually, yes.
Yeah. So both are equally important to
Important.
diagnose. Both of them you have to reach the hospital. Don't think, oh, it's positive, so I maybe get better. It doesn't mean anything. You have to still reach a doctor like him or us, and you do a scan. We see what's going on. I still remember there's an orthopedic junior friend of ours, MBBS, junior, and he suddenly developed this, unformed,
Hallucinations.
unformed phenomena. And finally, when we investigated him, he had a tuberculoma sitting in the occipital pore.
So you see, that was irritating and producing the positive
yes.
phenomena. Exactly.
And we had to go, and it was quite large, so we had to go and operate it and take it off and then medicated him. TB. Tuberculoma is TB in the vision area of the brain, guys. I had TB here, he had TB there. This TB is all over the place. He spoke about TB somewhere else. So
Yes.
this disease is crazy.
India, it's still a major problem.
It can be anywhere. It can get TB in the brain without fever. I had no fever when I got.
Doctors are especially prone because they do a lot of night duties, don't eat, and work very hard.
I agree.
See a lot of TB patients as well.
Absolutely, I agree. It's
doctors
deadly
in training.
Yeah,
They're especially susceptible.
So, since you are also an epileptologist, I would like to deviate a little bit and say how important is the so-called visual phenomena vis-a-vis epileptic fit, and how does that help you to interpret what is going on, and from a treatment perspective, so that we can cover that whole thing.
I think we have touched upon the aspect that positive phenomena are generally due to some excitability or irritation.
Correct.
So, like you said, you had a patient who had a tuberculoma. Now, what if this tuberculoma or some other, damage to the occipital lobe produced electric currents which spread around the brain? So that is called an occipital epilepsy. Many of these patients will have different phenomena. I had a patient who, due to birth injury, had developed damage to his occipital lobe. He used to have seizures with a very peculiar phenomenon. He used to say a cube of colors arose in his right visual field and went to his left.
Really?
Yeah.
Huh?
And then he would get a seizure. So that helped us. If it's arising in his right visual field, it's coming from the left occipital lobe.
Correct.
It helped us to diagnose it. And then he was operated and he's completely recovered.
But it's actually moving like that.
That is a classical example.
Amazing how incredible that is.
Right.
Very interesting. So that also helps you to localize.
So you can get a visual aura in epilepsy also, in occipital epilepsy.
So you get a visual aura in migraine, you get a visual aura in epilepsy, you get visual hallucination, which can be drug induced. So are we confusing the audience, or so eventually if you want to put everything together,
it's all coming from the occipital lobe. That's it.
Yeah,
different disorders are producing.
But they should still reach the hospital.
Absolutely.
And they should still get scanned.
Yeah.
And only if the scan is normal, you say hallucination, something else is there, you something else. But don't think that he will look at your face and say it is this and not this. It doesn't work that way.
Yes.
Correct.
We can have our clinical suspicions, but they have to be confirmed with appropriate tests.
Absolutely. So a lot of people, think that sometimes we tend to over-investigate, but a very simple way I tell it is, I can look at your face and tell your blood sugar or your cholesterol or your blood pressure. It has to be measured. So it's the same way.
Absolutely.
Evidence-based science is evidence-based science.
So we live in a time of technology,
exactly,
where not using appropriate technology is not proper.
It's
unethical.
It's a sin, actually. Yeah, to say it's normal, I have to do the test. And it's good that it's normal. Don't feel bad. Many patients feel bad that all the scans are normal. I said, damn it, you should be very happy that there's no permanent damage.
I would tell him the other way. What if it was not normal? Then you would say, Doc, good thing you did this.
Exactly.
Exactly.
And I agree.
I say now we're both happy it's normal.
Exactly. I agree.
You and I put together.
I totally agree with you. I want to change gears here and say, did you want to be a doctor?
Well, I always wanted to be a doctor, just like you, 6th, 7th standard.
Yeah? Excellent.
And somewhere down the line, I wanted to become a neurologist.
Mm-hmm.
Because I found neurology very interesting. Like what you said, unlike many other fields, there's a lot of analysis involved.
Correct.
You actually have to be a Sherlock Holmes.
I agree.
You need to ask a lot of questions.
Correct.
And then you'll come up with some elementary Dr. Watson, you'll diagnose it.
So and the bulb comes on, boom, boom.
It becomes very interesting to analyze the symptoms, examine a patient and generally from history and examination, narrow it down, and only then investigations help.
Correct.
Because you should know what to investigate.
Correct. Correct.
So I always wanted to be a doctor, and somewhere, when I was in, say, pre-university or so, I decided I should become a doctor of the brain. And during my MBBS, as I was exposed, it became stronger. And then when I started my MD in medicine, I was actually treating neurology patients, and I found it a lot more satisfying because it made me think a lot. So, and I
Correct.
like thinking. So
Correct.
I felt that that is something which would be very satisfying. A lot of analysis of the symptoms, and like you said, that's how we narrow it down and we know what to test.
Has there been times where you felt bad in the profession? I couldn't do anything. I couldn't help. Have you felt when in that? Can you?
So, well, practicing medicine, one as a doctor in training, very often I felt that maybe I felt very bad. Although logically there was nothing more to do. Everything had been done by our seniors, our professors, and everybody. But still, losing a patient or patient losing a function would devastate me when I was younger. Over the years, I have learned that being a doctor, one has to be objective too, often, and not lose one's judgment. Because once one gets emotional and upset, you lose your judgment, and
Correct.
it
The
impedes
balance
your professional
function.
approach
Agreed.
and the way you can actually help a patient. So while I still feel nowadays, I don't let it cloud my judgment.
Excellent. Well
And I
said.
try to do my best for my patient, and that is the state one should be while trying to do. I still empathize with the patients, feel their pain, feel their happiness too when they get better. Like I told you, the lady from Tumkur who got her vision completely.
Correct.
I revel when she became normal.
I know that
Both
nasha
of
is
us.
different. That nasha, I tell you, I don't think anything else will give us that. That's like a kick.
So that is something which I still live for.
Absolutely. Well said. Well said. And how do you? I know you have dealt with patients or families with death and disability that you can't avoid. Sometimes younger people and things like that. How do you deal with this yourself? How do you help the family deal with this? Is there something that you can tell? Because there'll be a lot of people listening to you.
So
Who,
one
how do
must understand the pain of the patient and the patient's family, empathize with them, know them that you're by their side doing their best. Many of the times we are successful, a few times we are not, but they should know that you're making the effort and that you're there with them so that they realize that the best medical care is being given. Beyond that, I think there is a force beyond all of us which we can't control. And, in our Hindu philosophy, we say that, this is destiny.
karma?
Karma.
Karma,
So,
destiny.
that's the only way one can look at it. But one must never stop short of one's duty. And one's duty is to feel the family's pain, empathize with them, tell them you're there, and in addition to that, do your best.
Correct.
That's the best one can do, I feel.
I agree. You also made a statement coming back to vision, that losing a vision or regaining vision is for people is they feel much more rewarding or much more this one than even having a limb weakness. So it's a very profound statement you made. Why would you make such a statement? Isn't that limb equally important?
I agree. But what happens is that
Like a weakness on one side. Why
exactly.
would this?
So, but over the years, last 25 years that I've been practicing medicine, I've come to realize that there's a disproportionate emotional component to loss of vision as compared to loss of any other function.
You have felt that, huh?
I felt that. And, they find it a lot more rewarding when the vision comes back as compared to power in a limb. They feel happy about that too, but they're very disturbed. Even a minor disturbance of vision causes a lot of emotional upset.
The human beings are very visually.
Exactly.
Diabetics.
I'll give you an example. Diabetics sometimes will come with double vision. So one nerve is working, one not the optic nerve, the ones which move the eyes, the third, fourth, and sixth nerves. So sometimes they come with the eyes closed because the third nerve is involved, or they see double, one eye is not moving outwards due to sixth nerve involvement. They are very distressed by it because they feel they can't read, and double vision disturbs people. It's not a big deal for you and I. We know it can be treated, sir. So, we treat them and, control the sugars, give some medicines to improve the function, and over a period of 1 month, they recover. And then they are like, oh God, how did this happen? I'm so happy now. So, there's that disconnect, as compared to other disorders, people feel very emotional about loss of vision and impaired
I
vision.
can share one story to drive that point home.
And
The 75-year-old guy, he developed this one eyelid got closed and he couldn't open it. And as a part of that, investigating that he was not a diabetic, and they went and got an MRI scan and all done, and they found that behind the eye there's the cavernous, there's a sac of blood called the cavernous sinus. He had a large aneurysm in
oh
the
my
cavernous
God.
sinus, pressing the third, and he just closed. So that was not his problem. His problem was he had cataract in the other eye because of which he could not. He was managing with this eye.
Ah,
Now this is closed. He couldn't see. He was devastated.
both eyes he couldn't see.
Huh.
Oh my God.
He said, I don't want to live, I don't want to do this, and they came and sat in front of me. Now it's an unruptured aneurysm. Now he doesn't care about this. He says, I want to see. Others, I don't want to live. It was so the question now, what was happening? They sent go to neurosurgeon. Then I realized that it was a very interesting deduction I made, so I thought I'd share. So I said, here is a guy who's got an aneurysm which is unruptured. Now that aneurysm required a special pipe we put called the flow diverter. You need a flow diverter. The moment we put a flow diverter, you have to put him on blood thinning medicine, strong blood thinning medicine. The moment I put the strong blood thinning medicine, you can't do the cataract surgery. And this guy, the ophthalmologist, can you stop the medicine? The first thing he's going to say, if I stop the medicine, that can get blocked.
So did you first do the cataract
Yes.
surgery?
So I told him, this can wait. You go and get the cataract surgery done and restore his vision to this eye because it will restore his confidence and belief in us.
Exactly.
So the family was actually thinking, what, this neurosurgeon is crazy, he's sending me in the opposite direction. They thought this was more important. But he got the cataract surgery and came back, Sujit, he was elated. He said, I can see now. Because I told him this eye may not open. Because so that this had to get fixed. Now he's post that 2 years, he's very happy. So even the sequence of how to treat.
Sometimes, we have to individualize the treatment according to the patient's wishes as well.
Exactly. It's called precision and
requirements.
personalized medicine. So it's very important to do that. And so I was thanking myself that, I got the wisdom to think through so much to decide which was more important. Aneurysm see, once we see an aneurysm, we start thinking, what's going to happen, and things like that. Though it's a larger one, doesn't rupture all the time. But anyway, so that, and she was very happy.
It's like a ticking time bomb, isn't it?
Exactly. No question
so
about
take that kind of balanced decision.
Yes, 1 month. Eventually, by the time this eye got sorted out, it was 1 month. Only then I could put him, get this FD and put him onto blood thinners and all of that, and everything went off well. So now we are coming to use. I also mentioned, you also mentioned about. So what are these eyeball movement nerves that are there, which you had mentioned at the beginning, that time has now come to cover that. So what are the nerves and what do they do and why are they important?
So there are 3 nerves. So they are called the 3rd, 4th, and 6th nerve: oculomotor, trochlear, and abducent.
Okay.
Those are just names. We'll call it 3, 4th, and 6th.
6 cranial
So
nerves,
these nerves are involved in various movements of the eyeball.
Okay.
Now, the eyeball we know moves up and down, moves to the
this.
side.
Yeah.
So different nerves are affected. Control different movements of that. I won't go into the details. Now these nerves, you might ask me that how do they come? Where do they arise? We know that the optic nerve arises in the eye. So these nerves arise in the brain, the lower part of the brain, what we call the brain stem, the lower part of the brain, and then they supply the eyes. So they arise from the midbrain and pons, which are parts of the lower part of the brain. And so due to diabetes and various other disorders, you told me this guy, it closed. How that closed? Because of an aneurysm, but it can happen even when the blood supply to the 3rd nerve is affected.
Correct.
Because
that's actually the more common.
Like you said, the cavernous sinus, the 3rd nerve passes through the cavernous sinus.
Correct.
So the wall of the cavernous sinus. So very often structures, either due to compression or due to decreased blood supply, do get affected, and with proper treatment, the double vision improves and the eyelid opens. So the common causes are all because of decreased blood supply. And then there are some rare disorders, like you were talking about cavernous sinus being pressed. There can be some inflammation of the cavernous sinus. Yeah, which can cause, multiple nerves being involved together.
I have seen the commonest 3rd nerve, which is the eye closing like this. They come to us saying he can't see. The question is not that he can't see. If you open the eyelid, he can see.
Yes.
He's not seeing because the eyelid is closed.
Exactly.
So it's an eyelid nerve problem and not an eye problem.
Exactly.
When I say that itself, they're happy.
Yes.
Then I have to open the eye and show, see, he's able to see and all of those things. And they know, but they want this reassurance what's going on. And I think the commonest the reason for the third nerve palsy is, I think, uncontrolled diabetes. Is it?
Correct,
Am I
correct.
right in saying that?
Correct, absolutely.
So you do still an MRI scan, make sure MRI is normal.
You gave us an example of an aneurysm. Now, the more common aneurysm can affect near the third nerve.
Thank you for saying
So
that.
there is a posterior cerebral artery,
PCOM, yeah.
PCOM, so posterior communicating artery. Sometimes, I think for the purpose of the audience, we should tell them what an aneurysm is.
Sure. Every blood vessel is a pipe. As the pipe goes and branches in different directions, these are weak areas of the blood vessel, and you can get a bleb or a bubble there. It's like your cycle tubes having this manufacturing defect, is what we call. So, and based on that bubble, it happens, that is called an aneurysm. It can happen anywhere in the body. Obviously, we also see it in the head, and this bubble can burst. So that bursts, and if it bursts, 1/3 of them die on the spot. 1/3 of them survive but remain unconscious, and 1/3 of them survive and remain fine because it's only mild headache. And those who remain conscious enough to complain, the headache, they say, is the worst headache of my life. So coming to that, so depending on where that blood base or the aneurysm is, very close to this eye nerve as it exits from the brain and comes towards the eye, it can cause the closure of that eye and create this problem. And that's what Sujit sir is talking about.
But like you said, it requires imaging because you want to rule out more ominous disorders like aneurysm from more simpler disorders like diabetes.
So bottom end of the day, guys, you have to have evidence, you have to image, you have to look at everything else and rule it out to come to the most simpler things and get that sorted. So if it is a diabetic oculomotor nerve affected or third nerve, do they get better with treatment?
Absolutely, they recover completely with treatment. So it's a good thing to approach the doctor. The doctor rules out more dangerous conditions and treats with simple medicines, and usually it takes about a month or so to recover. Most patients recover completely. And of course, here the rider is that you have to control your sugars properly.
Correct.
Unless the sugars are well controlled, this can happen again.
So this double vision. So how do you do a mapping for double vision? No, how do you pick that up?
Well, that's a technical sort of thing. We call it diplopia charting.
Correct.
But we can map the movements of the eyes with our fingers and see in which position the patient has maximum double vision. So that tells us which muscle is weak and which muscle is weak. See, generally what happens is the eye movements are equal. The right eye and the left eye move equally. So certain muscles are involved in a particular movement. So if because of decreased blood supply, one muscle is not moving and the other muscle is moving. So one eyeball moves, the other doesn't move. You can pick it up on clinical examination and do a more detailed objective diplopia charting and know which nerve is involved. Once we know which nerve is involved, we also do the scanning to rule out more dangerous conditions. So if somebody has double vision, it's very important to consult a neurologist so that they're able to diagnose it and treat it appropriately.
So thank you for that. I had one physician doctor whose friend called me one day and he said, this guy has suddenly developed a red eye. The eye seems to be bulging out a little bit and swollen, painful, and vision is blurred. So how frequent is that, you say, and what is this condition called and how important it is for a neuro-ophthalmologist in practice?
So what happens is that sometimes there is an injury or infection to the face and that goes through the blood vessels. You were mentioning the cavernous sinus. Cavernous sinus is a blood-filled venous vessel. It's called a venous sinus. So what happens is that if there's an infection and clot which forms there,
from our usual sinus, our sinus as sinusitis? Is that what you say?
It's different.
No.
Yeah, from the sinus, the infection can go.
So from this sinus, it goes to that sinus.
Venous sinus. So venous sinus is a blood vessel which has got walls which dilate to accommodate blood. But just imagine within this big venous sinus, the blood clots and gets infected. It exerts pressure and the eye comes out. It pushes the eye forward and the eye becomes congested, and it is called a cavernous sinus thrombosis, very dangerous condition requiring immediate hospitalization and treatment. Again here, although we can diagnose it clinically, we need a scan to confirm it.
Correct. And many people, this can happen because of the other sinus getting involved.
Exactly.
Our usual the sinus problem is what people say. That sinus that we have here, infection that you don't treat well can go backwards into the other sinus. So we have two sinuses. One sinus is full of blood, other sinus is full of air.
Yeah.
So this air flow getting infected will affect the blood flow, and then it causes an eye problem. It's so complicated, Sujit.
But
So
they're all next to each other. So
I know they're
could
all
very
next to-
well happen.
exactly, collateral damage or collateral
Collateral
effect at the
damage,
end of the
yes.
day. I agree, but that's what keeps us all going because and when I told him this is what has happened, he came rushing to my house at 10 o'clock that night because he was an MD physician himself, but he couldn't figure it out what was going on. And when I said this is cavernous, I said, oh, I didn't know that was possible, and he panicked, and then we had to put him in and whatever treatment we did, and he completely recovered. So even today, it's been 15, 18 years now.
So I think the important take-home message is that early treatment is very important. So
True.
meeting appropriate doctor, getting the appropriate
True.
tests, and early intervention is the best way.
I agree. I think that's the bottom line message that you're giving. Any more last messages you have? I think we have covered everything there's
I think neuro-ophthalmological disorders are very underdiagnosed. As
Correct.
we have emphasized, very often the symptoms are ignored. But God gives us only two eyes.
Correct.
And vision is subserved by the eyes and the brain. This is a concept that we wanted to bring out.
Correct.
So any disorder of vision, I will say vision, so it's both eyes and brain and the connections in between, one must not ignore. Meet the appropriate physician, neurophysician who's trained in neuro-ophthalmology, and they will do, apart from examination and history, they will do appropriate investigations and to finalize the diagnosis and then initiate adequate treatment so that, early treatment, as we all know, can reverse things.
Lots
So
of them. Yeah.
This is very important.
In fact, that's so most encouraging, I think, because the key the people should realize is lots of it can be reversed and not a small percentage. And that
Correct.
I think is very rewarding what you're saying. There's
Correct.
hope in spite of that. And
Yes.
obviously, visual rehab is something that we do very strongly.
Exactly.
And that also for those people with a stroke or something where the vision field is still there, we continue to do that. But there's one thing that we didn't talk about. We spoke about a field cut on one side, but we didn't speak about what is that visual neglect compared to?
I will tell a small story. This was an experiment which was done in the 1980s.
Okay.
So, when the brain has got a dominant hemisphere and a non-dominant hemisphere.
What do you mean by a dominant and non-dominant?
Dominant is supposing I'm right-handed. The left controls the language and memory. So that's why I'm right-handed. So the left is a dominant and
so
the
whatever
right.
controls the speech and hand is called.
Exactly. It's the dominant hemisphere. Now, if the dominant hemisphere is involved, we have language and memory. Neglect is something which happens in the non-dominant hemisphere. There was a very interesting experiment. There was a patient who was taken. He was shown a cathedral in Italy. And then he was a patient who had a stroke and purported visual neglect. And then he was asked to draw it from memory. He drew only half the cathedral. The other half he couldn't draw. It's not that he was not seeing it. It's just that the brain was neglecting to interpret the other half of the image. That emphasizes, the story emphasizes what is visual neglect.
Very, very simply and very effectively. Very effectively. Very interesting. There's one more thing that we didn't talk about was visuospatial problems. Root finding difficulty, visuospatial.
Correct.
What is visuospatial? Can you explain?
So I'll give you an example. I had this patient who was having a lot of memory disturbances for quite some time. Then one day his wife said, "Doc, I don't know what to do." An elderly man. So he went yesterday to bank and he couldn't find his way back. Got lost. Can you believe it? Then somebody he knew, because they're in the neighborhood, somebody he knew brought him home. Then his wife said, "No, going out again on your own." So this is a classical example of visual spatial disorientation or geographical disorientation.
Now, why does that happen? What's the connection to the brain?
So what happens is the parietal lobe has connections to the occipital cortex.
The parietal is the area of the brain that's here.
So that controls the, what shall we say, wear. The wear of vision. So, what happens is that there is something called a dorsal and a ventral stream. They are fibers which connect the visual association areas. So what goes into the parietal lobe controls the visuospatial disorientation and orientation and all that. What goes into the temporal lobe controls what? The colors, objects and things like that. So disruptions in these can produce these symptoms. It can happen in stroke, it can happen in, Alzheimer's or dementias, it can happen in tumors. I think we heard a story by Dr. Dugani about one of his patients who would get out of the wrong bus stop and
Correct.
he couldn't find his way home. Then he'll realize after some time.
Correct.
So these problems can occur, and that was due to tumor. So that can also produce these symptoms. Basically, when the anatomical and functional connections are lost, these problems can occur.
We have a dialogue we put in Kannada, Dari Tappida Maga tara. But
Yes,
that
sir.
Dari Tappida Maga
Yes,
can be
old-
quite a dangerous thing because,
Quite,
it can really go. I know one of our very famous, elderly man who was same way, was found roaming in the street in Malleshwaram, and somebody found him, and he was in early Alzheimer's, and lost his way home. Same house that he lived for 50, 60 years. He couldn't find
couldn't
the way.
remember it. That's very
Yeah.
sad, isn't
It was
it?
just, very sad, very sad. And I've also known patients instead of going to a puja room, instead of going to bathroom, they go to puja room and to, pee there, do
That
susu
happens.
there.
That
Yes,
happens.
and in their own house, they're getting lost,
But
disoriented.
yeah, that's very sad.
Very distressing. The family is distraught, but what is going on? They don't know what is to be done, and it's
Just one more thing, while we were on the aspect of this higher processing
Hmm.
of visual information, I came across a patient who had a stroke.
Mhm.
The strange thing was
Hmm.
he could write, but he could not read.
He could write but not read.
Not read. He had what is called alexia without agraphia.
Ah.
So basically, what he could see the letters, but his brain is not interpreting it properly. That happens when the left occipital lobe and the connections to the opposite
Correct.
side are
Splenium,
affected.
the
Splenium is
splenium,
affected.
yeah.
So let's forget about the exact nuances of it, but the fact was it was a very disturbing. And then with treatment, we found out it was because of a stroke, and with treatment and visual rehab and all, he was able to do it later.
I'll tell you my own first encounter with an Alexia guy was a guy when I was training, and we were, as the word doctor, I had to obviously do all these tests and all of that. So I dictated to him, and he wrote beautifully. He wrote what I dictated without any mistake. Then I told him to read what he has written. He couldn't read a word.
Wow.
And I had read about it in the book. I looked at it. I said it was exactly what it was in the book. Then I said, copy. He copied.
The writing was intact, reading was not.
It's amazing, no?
Amazing.
Oof. I said, shit, this is like incredible. And then he had the back portion of the brain that connects from the right to the left called the
Yes.
splenium. That he had a glioma, that a
Oh my
cancerous brain
God.
tumor. We biopsied, but didn't do well. That didn't come back. It is crazy. Oof, it's just how strong the visual system is in human beings, and so many connections to so many functions. Why we chose this is because the humans are very visually heavy. We have so many connections, and even what we think is visual. No,
Correct.
can you say
Absolutely.
anything you have to say about that? How we think? We don't think in language, but we think more visually.
Yes,
There
is something called a verbal memory and a visual memory.
Okay.
So the verbal memory is always in the dominant hemisphere.
Correct.
Visual memory is in the non-dominant hemisphere with a good connection to the temporal lobe.
Okay.
So a lot of the memory is visual. So if I see 10 objects, I remember it like that. I think like that. I think about objects like that. When I think about my house, things come. The picture comes.
Correct, picture. Like if you say banana balan, you don't see BANANA. You look at the banana as a shape, Car means shape. That's why, because even we are thinking visually.
So phylogenetically, the vision, like I said in the beginning of our, is one of the oldest parts
Correct.
of our nervous system.
Correct. Absolutely.
So it has been preserving us for, what shall I say, centuries or.
But it's so fascinating. I love the visual system because it has so much to do, so much to check, so much to, to
And
take care
as
of.
we go deeper into it, a lot of things are revealed to us.
Exactly.
So
Exactly.
So I will reiterate that the vision gives a lot of information about many other parts of the nervous system as well.
Correct. Yeah. So
and
that
many neurological disorders.
Correct.
So complete examination of the vision and further investigation is very important in patients presenting with visual disturbances.
And checking, making them right, making them do this, do that. Because some subtle thing can even pick up sometimes. The MRI can miss it in the beginning, but it may be something else. so you can chase it and do that. I think, Sujit, it was a great conversation
Very-
that we had. Any last messages that you want to give?
We had a very fascinating discussion.
I know.
I'm myself very, enlightened, and I feel very good that we discussed so much.
Don't you think so?
Yes, absolutely.
And so
We've exchanged so many stories too.
I know. It's great. So I'm hoping, guys, that we have made you understand two things. Eyesight is not equal to vision.
Correct.
People say he's a visionary. They say visionary, that's different. But here we are fundamentally talking about things that you can't interpret, number one. And more importantly, he said, chase it quickly because a lot of it is reversible. Guys, you can
Let's
treat it.
not ignore visual disturbances.
Yes. And what is it, positive visual problem or negative
Negative.
visual problem? A whole big fellow, small fellow, mild fellow, red desaturation to everything else, guys.
So I'll end with a small story.
Sure.
So this is from trivia. I think most of you have read Alice in Wonderland.
Yeah.
Alice in Wonderland
Yeah.
by Lewis Carroll. Did you know that Lewis Carroll
Mhm.
actually suffered from migraine?
Oh,
He
no.
had a very peculiar aura.
Okay.
It was called micropsia and macropsia. So sometimes
Oh, huh.
during the aura,
Hmm.
he would see people smaller and people
Oh.
bigger. That's what incorporated into Alice in
I
Wonderland.
didn't know this. Really? I
Absolutely.
didn't know this part of it.
So Alice will eat a cake and become small. She'll
Yeah,
eat
yeah,
something
no,
and
no.
become
But I
big.
didn't know this. I didn't know the source was a migraine.
Oh my God.
So interesting. So you can even have positive benefits.
Even historically, it's been there since time immemorial.
Correct.
Visual
Exactly.
disturbances.
Exactly. And people have written it and documented it in different ways.
Exactly.
So very interesting. Thanks, Sujit, for a
you very
fascinating
much.
conversation. I think this was a great topic that we chose. And I think I feel that we have done full justice to what it
I
has
think we
to
have
be.
covered the plethora of
I know.
visual disorders with
Absolutely.
interesting anecdotes.
Absolutely. Thank you very much.
Thank you very much.
So, guys, before I finish, the usual housekeeping rules, don't forget to subscribe to our channels, which is the YouTube, the Facebook, the Instagram. Forward these videos, the shorts, the long ones, to as many people as possible. You see, another fascinating conversation we had today about what it is to have, eye okay, but not the vision. Please hit the subscribe button, share, hit the like button, and most importantly, put your comments. Comments, guys, is very important. Many of you are watching our videos and not yet subscribed to our channel. Please do that, because it's very, very important to inspire us and encourage us to do more things. And don't forget to watch the Rebooting the Brain documentary. And we also have, interestingly, a Beja Unfry, a web series that we made about our
I
life.
know.
6-episode series where our Jamil Jamali, Rakesh Bedi has
Yes.
acted in that. So you can have a look at that. That's a trivia for us. That's all, signing off from the Rebooting the Brain studio. Till next time, have a great and envisioned and enlightened day. Jai Hind. Sujit, there's a part of the protocol of this one. We give a book for all our guests. That's
Thank you
your
so
copy
much.
of the book, Rebooting the Brain. So fascinating stories, more and more stories. I
Yes.
think it's very important for patients to understand stories, and through that, learning happens and then awareness happens. Thank you very much.
Thank you very much.
Welcome.